27-year-old female presents to ED with complaints of acute onset fatigue, blurred vision, rash, and her husband is telling that she was exhibiting changes in her mental status and had trouble speaking. Her vitals are temperature 38.4, heart rate 87, BP 110 over 85, respiratory rate is 14, and saturation is 96% in room air, which is stable. Physical examination reveals petechiae pallor and left upper extremity weakness. Workup reveals HP of 8.5, platelet is 22,000, normal PT, INR, APTT, absent fibrin split products, elevated fibrinogen, a negative Coombs test, 3.7 milligram per deciliter of creatinine, 3.8 milligram per deciliter of indirect bilirubin, and LDH is 1000. Which of the following would be expected on the peripheral blood smear from this patient? So first you have to be clear of the diagnosis. So this patient is coming with neurological symptoms. That is, there is fatigue, there is blurred vision, there is trouble speaking, there is change in her mental status. Okay, there is left upper extremity weakness, and then there is petechiae. Then there is in the lab there is thrombocytopenia, there is anemia, but the PT, INR, APTT, fibrin, there is no fibrin split products or fibrin degradation products or something like D-dimer. It's all negative. Fibrinogen is also elevated. That means it's normal. It's not low. So the DIC is out of picture. Negative Coombs test. So autoimmune hemolytic anemia or anemia is out of picture. There is high creatinine, so there is kidney dysfunction. Indirect bilirubin and LDH of 1000. So these all come together to a diagnosis of microangiopathic hemolytic anemia, which is called MAHA, one of which is TTP. So you have TTP, you have HUS, both of which can present with these symptoms, but in TTP you have neurological predominance, in HUS you have the renal predominance, and also in HUS there usually would be a preceding history of diarrhea, usually with an E. coli. So in this case, this is TTP. So what do you find in peripheral blood smear? That is, there is fragmented RBCs due to hemolysis. That is what you see in MAHA. So the options are ovulocytes, spherocytes, atypical lymphocytes, schistocytes, and rouleau formation. So it is schistocytes or fragmented RBCs. Ovulocytes you see in hereditary erythrocytosis. Spherocytes you see in hereditary spherocytosis. Atypical lymphocytes usually seen with viral infection like infectious mononucleosis or EBV infection. Rouleau formation is with multiple myeloma like picture, like stack of coins or coin like appearance. That is called rouleau formation seen with multiple myeloma. So in this case, it is schistocytes, which is fragmented RBCs seen with TTP.